The work interface design, not only to facilitate technicians' work, but also to favor patient comfort, are usually forgotten, and to me, are part of the general concept of technology designed for efficiency. And in this sense, being able to perform the positioning setting and the start of the study from the in-room is an example of efficiency. The Vital Eye and the brisk coils are other examples of simplifying processes that improve daily workflow. And finally, cardiac MRI is special. It requires ECG synchronization and acquisition of images during respiratory apnea. So this implies giving the instruction for each apnea slice by slice during approximately 45 minutes, and that is only one of the 5-6 studies that are performed in each session. So think about it. These people spend 5-6 hours a day giving the same instruction over and over and over again. So the auto voice not only preserves the mental state of the technicians, but also allows to be optimized, time to be optimized, and the next sequence to be programmed on the fly. So what about cardiac MRI? We currently carry out practically all the standard cardiological protocols available. Scene images suitable to study structure and cardiac function, classic T1 and T2 black blood, T1 and T2 mapping sequences that allow quantification of T1 and T2 times to better characterize myocardial tissue, phase contact sequences to study valve fluxes, angiographic sequences to study vascular structures, for example, pulmonary veins, first pass stress rest perfusion sequences suitable to study coronary flow limiting stenosis, and of course, the late gadolinium encasement where you can see straightforward white on black, necrotic or fibrotic tissue. And just regarding these sequences, you must remember always that white is bad. So let's see a few examples. This is a patient with moderate aortic regurgitation and paroxysmal lateral fibrillation. We perform cardiac function and fluxes in order to quantify aortic regurgitation, and also an angiographic study previous to pulmonary vein ablation, which basically involves an intervention to burn myocardial pocket of arrhythmia. And see, look how great the level of detail is. You can see all the pulmonary veins and even second and third level branches. So the idea here is to fuse the volumetric 3D images with the electroanatomical cardiac maps obtained in the intervention room in order to guide the catheter burn line. So we are talking about precision on a scale of millimeters. So you can imagine the importance and the great need for excellent quality MRI images. Of course, we also study cardiomyopathies by CMR, and this is a case of a 23-year-old young man with basal ECG abnormalities submitted to further study by MRI. Standard cardiomyopathy protocols include cardiac structure, of course, and function, inversion recovery LGE sequences, and mappings. And look at the scene. Note the asymmetrical anterior hypertrophic myocardium with normal LV function and no LV outdraft blood flow obstruction. And in the LG images, it is easy to see a huge compact gadolinium focus matching the segment with the greatest hypertrophy. So this is a fibrotic tissue and of course has prognostic implications. So CMI is a really central image modality to re-stratify cardiomyopathies. Also in this case, T1 map firstly help us to discard other possible differential diagnoses mimicking hypertrophic cardiomyopathy, for example, amyloidosis or Fabry disease, which are pathologies with completely different treatment and prognosis. And T2 confirm no presence of myocardial edema or myocardial inflammation. So definitely the multiparametric power of CMR allow us to identify in the same study many aspects of complex pathologies. So finally, another daily MRI study request are patients complaining from acute or chronic chest pain. In this example, scene sequences show us an inferior myocardial motion abnormality with moderate LV dysfunction, and we could say that evidently something bad has happened to this muscle. And in the LG images revealed in white a subendocardial infarction. So in this case, we arrived late because scar is already there, but maybe more myocardial tissue is in danger and needs to be saved. So the protocol is complete with first pass perfusion sequence at stress compared to rest images, and an extensive inducible perfusion defect was revealed in the inferior and lateral territory, denoting a coronary flow-limiting stenosis in 2 cardiac territories that should be treated to prevent further damage. So to wrap up, I would say that cardiac MRI is a unique study that has high impact in patient management, but to do so, MRI needs to adapt to patients' complexity. And I really believe that 5300 Philip MRI has great qualities in this way. Easy and fast patient setup, very robust sequences, and in the very first day with minimal adjustments, we organize almost every cardiac protocol with these excellent quality images I just shared with you. And even more relevant, it has the entire wide range of consistent sequences needed to cover all the type clinical needs. So what about the future? Maybe the next step is to make CMR more available in terms